Started. I wanted to welcome you again to the Critical Care Medicine Seminar. And today it's my privilege to introduce to you Dr. Brian Barbaro, who is currently a clinical associate professor at the University of Michigan within the Department of Pediatrics and C.S. Mott Children's Hospital in Ann Arbor, Michigan. He obtained his undergraduate bachelor and MD degree from the University of North Carolina, UNC at Chapel Hill, where he also did his residency in pediatrics. And he completed his fellowship in pediatric critical care at the University of Michigan, and then went on to do a second fellowship in pediatric health services research. Dr. Barbaro also obtained his healthcare research from the University of Michigan, and he is currently the pediatric ECMO director at the University of Michigan Mott Children's Hospital. Over the years, he's accumulated numerous honors and awards, including the 2014 Young Investigators Award for the Euro Extracorporeal Life Support Organization, the 2017 Star Research Achievement Award from the Society of Critical Care Medicine, and the 2019 Presidential Citation for the Society of Critical Care Medicine. He also serves on several international, national, and institutional committees, and he's currently the chair of the Regional Committee for ECMO Life Support Organization. He's an executive committee member of the Pediatric ECMO Anticoagulation Collaborative, or PEACE, and a member of the International Pediatric Acute Lung Injury Consensus Conference. Dr. Barbaro's research interests center around improving ECMO support in children by analyzing how hospital structures and processes of care can influence patient outcomes, and he's interested in improving the neurodevelopmental outcomes of children receiving ECMO support. Dr. Barbaro is also a R01 funded investigator with 2 active grants currently. He's the PI on an NHLBI R01 entitled ARDS and Children in ECMO, Initiation Strategies, Impact on Neurodevelopment, or ASCEND. And this is comparing the short and long-term patient outcomes of children who are managed with mechanical ventilation protocols, where they reserve the use of ECMO until protocol failure, compared to the alternate group of standard care ECMO. He's also an R01 co-investigator with Dr. Ronald Herschel on pediatric implantable artificial lung that evaluates the safety and efficacy of pediatric artificial lungs in an infant model of end-stage lung disease. Dr. Barbaro is a sought-after nationally and internationally speaker, particularly on the ECMO circuit, no pun intended, now being a very hot topic in the era of COVID-19. And he has a track record of mentorship with junior faculty, residents, and fellows, and has over 60 publications. Today, he's going to talk to us about respiratory ECMO support in children. Welcome, Dr. Barbaro.
Thank you so much. All right. Thank you so much for the opportunity to be here. I couldn't be more excited to be here with this team of folks and really fantastic friends. In what turns out to be great weather as well, despite the rain, and talking about something I care a great deal about, ECMO support. And so, as I alluded to, this wasn't taken just before I left, but it was representative. And this wasn't taken today, but also seems pretty representative, except for maybe the azaleas have already bloomed. Yes, there are certainly climate differences, which are appreciated here, but also I appreciate the fact that we're coming from 2 institutions, or I'm coming from an institution at the University of Michigan to Children's Hospital of Atlanta. They really are both well steeped in ECMO support. And so I'm not going to try and tell you how to provide ECMO support, but I do want to do, I'll talk about in a moment, is just first recognize that a lot of what I understand is built upon the foundation of wonderful mentors, both at the University of Michigan and here, and Jim and Matt. And that actually, at the beginning of my research career, I spent some time here with Matt and Cheryl Stone doing some research I'll reference a little bit later. In terms of disclosures, as was named, I am the ELSO Registry Chair, report up to Matt as the President of ELSO, and also have the opportunity to lead, as was said, an R01 study called ASCEND, which I'll talk a little bit more about as well in the study. In terms of why I'm up here talking about ECMO support, it's really more of a frame of what kind of excited my professional aspirations. And so clinically, as a young fellow, it's invigorating to be able to, is it okay with folks? Right. It was invigorating to be able to be a part of kids who are at the very pinnacle of critical illness. It was really rewarding to be able to walk families through that crisis. And it was just exciting to be a part of a team that was all pointed in the same direction and like coming together in real time. In terms of research, actually also for me, came off of a clinical experience that I had had. So I was at, as was said, the University of North Carolina, which had an ECMO program, but we just didn't do as much ECMO support during that time, or as a resident, I didn't encounter it that much. But in the very final month that I was at UNC, I put on my first ECMO patient as part of a team. And then, no surprise, in my first month at the University of Michigan, I was there to put on a patient. And there was this juxtaposition of these two experiences, which ended differently, but were done very differently as well. And that just experience of being like, oh, wow, this is really different, made me ask, are there different ways that we can help deliver care that would impact the outcomes of those patients? But the thing that really got me was the community. I've already made reference to some of the community here. At my own institution, the people who mentored me, and Gail Onick and Bob Bartlett, and many others, as I expanded beyond that to our local team more broadly, and to the ELSO community, I just found time and time again that the people that I encountered were motivated and invested to teach me, nobody, how to drive this care forward because of the belief in the patient. They were willing to dedicate time, Cheryl Stone and Matt Payne, to helping me launch the research things that I was interested in. And they were just there to help to support. And I think that has been time and time again my experience across the ECMO community. And so what I want to talk about today really are just three conversations, I hope, around some unsolved problems, at least as I perceive them. If they are solved for you, please tell me. So those things really are focused around when to initiate ECMO, how to improve the team, and here I'm focusing more on ECMO, and then what to do in the face of the unknown, and I'll leverage a personal experience around COVID-19. I'm going to notice a theme of just identifying people who have been really helpful in making me think about things. That community thing is, for me, is really important. But Joe Custer was a division chief at the University of Michigan before I got there, and ended his career shortly after I arrived. So I'll try not to take that personally. But he offered in a letter to us as he retired some parting thoughts of an intensivist. He was a guy who believed deeply in himself as a coach, as a person who was bringing up the team. He was a phenomenal physician, but he also had a wonderful way with words. And so I took the opportunity to quote him to kind of lead into each of these points. And so the air goes in and out, the blood goes round and round. Do not alter that arrangement. And so unfortunately, that's exactly what's happening with many of our patients that we decide to transition towards ECMO support. Each of these are patients that we did ultimately place onto ECMO. Each of them actually had different paths through ECMO. Some of them did not survive. But I think those experiences helped me think about when should we initiate ECMO, and recognizing that when we're doing that, we're making a pivotal decision that is going to change the trajectory of a patient. And so, right, like why break something why fix something that's not broken? Let's just take the typical approach that we take to all medicine, which is just, hey, when do the potential benefits outweigh the risks? And so what are those benefits? What are those risks? I think the most obvious and evident thing that we're trying to do, and it's what all clinicians say they're trying to do when they make a decision to transition to ECMO, is to reduce the risk of death. I think that, maybe some more forward-thinking folks would also think about, are we able to reduce some of those complications that might occur if we were to continue down the current trajectory as well? But first, let's just examine what the evidence shows in terms of reducing deaths, and also think about where this evidence is coming from and what its current context is. And so in pediatric medicine, our really landmark trial still is the neonatal trial in 1996, which demonstrated a 26% reduction in mortality, just a staggering reduction. Now, that reduction was certainly in a context that I think is a little bit different to where we are now, and I'll speak to that a little bit later. And by the way, each of the asterisks are just pointing out things that were statistically significant in that analysis. And so the CSER trial in 2009 was an adult-oriented trial about acute respiratory failure. that was really similarly modeled to the UK neonatal trial, but was more critiqued for potentially not representing just ECMO care, but rather the body of care that was delivered at an institution that was able to deliver ECMO. And so the mortality reduction was 8%, the absolute reduction in mortality. But the primary outcome, which I think actually is probably more significant, which is this combined outcome of death or disability, was statistically significant at 16%. The EOLIA trial in 2018 showed an 11% difference that wasn't statistically significant. There's been a lot written about why that was. I'm going to brush over that for the time being. The NOAA, and then the next set of three are just observational studies that have kind of looked at specific populations. NOAA is a JAMA published article that looked at the H1N1 pandemic and kind of tried to, in an observational manner, recreate the CSER trial and found a 29% reduction. The pediatric acute respiratory failure was a study of convenience that we did using the restore sample and the 60 patients that received ECMO support there, and non-statistically significant difference of 5%. And then the Stop COVID group tried at the beginning of the pandemic when folks really were uncertain about whether or not to place folks on ECMO, what they could see in a propensity matched approach to that. And so, and they found a 13% reduction in mortality there. And so, while I acknowledge and recognize that these studies are not in pediatrics, I think they do create a preponderance of evidence that can at least allow us to say, yeah, this is probably going to be a benefit in terms of saving lives for children. And so, but I do want to just also emphasize that these are different populations than the kids that we're caring for. So the kids in the UK neonatal trial obviously were neonates less than 28 days. They've been intubated for less than 10 days. The EOLIA trial, where the average age was 52 years. I mean, you know, we coined the phrase, right? Kids are not young adults. I think the reverse probably also applies. And so I think that they're different populations, but I think that they don't do as great a job. They're in terms of those switching gears and thinking about those potential risks. I think that clinical trials are really going to be the only way we're going to separate out what are the risks of clinical illness from the risks of ECMO. And so recognizing that these studies weren't powered to the secondary aims of looking at those risks, but also recognizing that when we look at these observational studies that report out which I'm going to show and talk about in a minute, what the problems are that we encounter on ECMO, or that are associated with ECMO, it's really hard to disentangle what of that comes from just critical illness generally. And so in EOLIA, which enrolled 120 folks to both arms, there was no difference in these things of hemorrhagic stroke, cardiac arrhythmia, arrest, pneumothorax, renal replacement use, things that I think probably to us resonate as things that are going to matter to families. There were things in terms of thrombocytopenia and bleeding, which I think make logical sense in terms of circuit exposure and anticoagulation, and maybe are something that our families would be willing to trade off. The UK neonatal study, importantly, showed no difference in neuromotor developmental outcomes, but did show differences in terms of lower respiratory ECMO and fewer behavioral problems in the ECMO versus control. And I point that out not to say that that necessarily these things were better in the ECMO group, but they certainly weren't made worse by the ECMO group. And so, sorry that this isn't quite displaying the way I'd hoped for. This is a cannula and the remaining part of a cannula there. But I think what I want to draw your attention to is here on the right side, some of these are just observed complications that happen in children who require respiratory ECMO support. And so you can just see that, hemorrhage is around 16%. This is maybe ill-defined and is really important as we think about progressing the field, but is something that certainly that we would all worry about as clinicians as our child there. Infarct, seizures, maybe the use of dialysis is less important to us, and maybe it's not even being used as a complication in that 36% there, but it's something to take note of. And then some of those pulmonary and GI hemorrhages at 8 and 16% are certainly worth us thinking about. And so when does the scale tip? When do we think, hey, given those risks, given those benefits, when do we want to transition? And so there's certainly some anchors that we can look to in the literature. The UK neonatal trial used an OI of 40, a PaCO2 of 90. The EOLIA trial, the most recent representation in adults, used a PF ratio of 80, a pH of 7.25 with optimal ventilation. But this isn't really early, right? I mean, like when we're talking about transitioning to ECMO, we're talking about something that's almost 3 times the definition of what we talk about in terms of severe ARDS. But earlier maybe is better. And so when we look at that UK neonatal trial and they looked at those patients who were between 40 and 60, which is here, it looked like that it favored ECMO even more relative to those that were greater than 60. And the OLEA trial, which I've emphasized a couple of times, is not a positive clinical trial, but the direction of the evidence points in the same path, which is those patients with a higher PF ratio, and 66 is just the median relative to that enrollment criteria of 80, seem to do relatively better than those who were sicker and going on a bit later in terms of hypoxemia. And so it is recognizing this space as an opportunity for us to kind of fill a gap that really did push us towards trying to understand when is the right time to initiating ECMO so that we can hopefully minimize some of those complications that are important, or not at least expose patients to them unnecessarily to the extent that ECMO is contributing. And so we aim to do two things. The first is just generally to recognize what those outcomes are for children who have pediatric ARDS, go on ECMO support, and what that functional status and health-related quality of life is a year beyond that. But we also wanted to leverage an ongoing clinical trial that created this externality that said, hey, transition ECMO support here and compare groups that had that externality versus patients that just received ECMO pragmatically and in a natural practice way. And so in that manner, we were trying to emulate a clinical trial in an observational frame. And so Prospect is the study that I'm referring to. And Prospect is enrolling, ideally, though probably not practically, 1,000 patients with severe ARDS. They have a protocol that defines how you should be conventionally mechanically ventilated and ventilated with high frequency oscillatory ventilation. There's also a bit about prone and supine, which I'm just going to breeze by. But the peak that we observed that patients were generally going on to ECMO support in the ELSA registry at the median was 10. And the recommendation is at a peak of around 6 to 18. That's the protocol that's designed. And so that's when you would think about transitioning over. Now, some physicians may decide that it's best for the patient to transition ahead of time, but this is more of an intention to treat analysis, that this is how things were set up. And some of those folks on the oscillator, we observed go on at 28. You can see there's a big spread, 24 to 32, but all of that is less than where Prospect is identifying a failure in the protocol at 35. And so that leads to that aim two, which is we will test this hypothesis that there's a difference between those folks, both in the short-term outcome, that mortality benefit that we're looking at, and perhaps trying to account for some of that critical illness stuff that's related to ECMO or not, and looking at some of those longer-term outcomes with admittedly coarse instruments in terms of the functional status scale score and the PEDS health-related quality of life. In terms of who those folks are that we're looking to bring on, we are bringing on both VB and VA ECMO support, 14 days to 17 years, which is just mirroring the age settings for Prospect, less than 7 days of intubation. And that's just because we're trying to kind of set this up as the same type of early entry into our imagined trial here. And then moderate to severe pediatric ARDS had been severe, but Prospect has encountered some difficulties in enrolling patients, has reduced its enrollment criteria. And so we have as well the expectation still that there'll be severe pediatric ARDS. And then bilateral lung disease in the absence of excluding diagnoses, which are substantial, but fall into three broad categories of, hey, it's probably not ARDS. They have a left-right shunting lesion, or they have CDH, or they have known cardiomyopathy, or hey, you in the Prospect arm of this aren't going to be able to treat the patient per the protocol, meaning you have an intracranial bleed, or you have an unstable neck and aren't going to be able to be prone, or an open abdomen or something like that. And then the final kind of group is, hey, I don't really think that the way you're cared for is going to be the major driver in your outcome. Your status post a lung transplant, you have bronchiolitis obliterans, something like that. In terms of Ascend, it is actually a thing. It exists. We have patients enrolled in it now. We have 70 patients enrolled, which is a long way away to our target of 550. We have 80 sites up and going, which has been really exciting to get going across 7 countries, which has been wonderful education and contracts and rules in other countries. We have our first patient completed their 1-year follow-up also really exciting. And we've enrolled our first patient outside of the US. So like we truly are now an international study. And approximately half of our patients have COVID. So excited about thinking about some of the opportunities to learn in this new space around those patients as well. So we don't have to force questions, but I wanted to pause there because I'm going to take slightly different gears to the different elements of this talk, and just if folks had questions, provide a space for that.
When you came up with the whole idea for the trial, I mean, COVID was not even, that was not even part of it, correct?
Yeah, so if I laugh because we literally said in the grants, like dealing with contingency planning, that in the unlikely event that a pandemic should occur.
So your fault.
Yeah, it's my fault. It's my fault. I'll write another grant 5 years saying in the unlikely event that there's world peace. But I think the thing is, Prospect is encountering that same thing, so we should be able to match up similar patients. But unquestionably, if you were to say, if I was to ask Matt, like, Matt, who is the typical patient that you take care of in your unit? I think most of us would describe a toddler in terms of ECMO, support for a respiratory indication. It is not the case anymore. That is a huge change. And I think is pushing us to think about how we're doing things similarly or different from our adult colleagues. And that's a good reflection to have. I think we, for the most part of ECMO, have given our adult counterparts the opportunity to think about what pediatricians have done. And it's great to be able to reflect on that from the others. Shu. All right. Another Joe Custer quote: "We often are challenged to formulate and communicate a daily plan, but willingly predict an outcome far into the future." So I will make both of these mistakes. So this is a kid who I think did challenge us to think about this. And so, we have been part of these cases, ECMO or otherwise, where we cannot see the end in sight. And sometimes we persist with benefit, and sometimes we persist with suffering. This was a happy story. This child was on ECMO with us for over 90 days, or just around 90 days. I think, in a large way, we didn't anticipate that he would do well as he was coming off. And so this is 60 days off of ECMO. This is his chest x-ray. I'm not sure I might need to cannulate him still, but he did okay. And I actually highlight the imagery of this because I think this is something that we do a lot, where we look at an image, we're like, this kid's going to have this outcome because of this image. And I don't know what's going to happen to kids. I try to express what I think might happen. But at the end of the day, I genuinely don't know. And we're so far, oftentimes, when we're talking about those cases, into the rare and unexpected, that I think it is hard for us to predict. But this is his 3D CT a year later. I think there's also an opportunity to look at here opportunities for rescue or failure to rescue. And so this child ended up he went on VA ECMO for sepsis and ARDS, went into cardiac standstill, had pulmonary hemorrhage, and actually probably protected a lot of his lungs for a bit as we took time to dig out all of the clot there. We tried some creative things in terms of endobronchial valves and things along those lines. But I think it's an opportunity to just reflect on that fact that we are all going to experience complications. Hopefully we learn from those and minimize them, but also hopefully we prepare ourselves to rescue those patients from that. And this is some of the work from Justin Dimmick and at Michigan, who I have kind of pioneered some of this thinking around failure to rescue. But namely, it's not that the complication occurs, it's in how you respond to that and prevent those domino complications that exist, which we've all experienced. That kid, once you have one, you have multiple that move towards death. And so this frame, though, really is around thinking about how we can improve the team, both from a broader, hey, this is for all of our patients. How can our team do a better job in caring for patients? And our smaller, hey, we have a patient in front of us right now. How can we think about caring? And so this is where, prediction comes in. And so it's not prediction per se, actually. It's about thinking about adjusting for the risk factors so that you can maybe benchmark and look across institutions. And so we tried using the ELSA registry to develop a score that would identify those patients who are more at risk for death. And we did not great. And so came here to CHOA as well as to another center in our own to think about if there's opportunities to improve the model, and found actually that some things like lactate and ALT, sorry, I said that reverse of the image, may actually probably be driving some of those differences. So just thought about adding those things into the model as well. And then leverage those models as well as numerous others to help us build a quality reporting platform at ELSO, along with our partners at Arbor. And this is really, I think, an opportunity for us to think about how we can leverage benchmarking opportunities as not a thing that's going to tell you what's wrong, but as an opportunity to reflect on what you're doing and where you can improve. And also an opportunity to look on the how, the process measures. And so here's just a binary definition of whether or not at 24 hours of going on ECMO, you have a peak expiratory pressure less than 25 centimeters of water. I'll speak in just a couple slides to why, but first I've set up these kind of two paradigms of looking at processes or looking at outcomes. And there's good reasons to do both, and there's good reasons to not do either in ECMO. And so focus on outcomes has the disadvantage of not really having evidence to link that outcome to what you should do, right? So like if you notice that your mortality is worse than your peers, it's not immediately evident to me how I can fix that. And processes, because of where they're defined from, usually from randomized clinical trials, high quality of evidence, they often narrowly apply to a specific disease because that's often how we design clinical trials. In fact, in ECMO, because it's such a heterogeneous population, these actually hasn't been as much the case. We've generally defined the populations that we've looked at as having acute respiratory failure or ARDS. And then or a focus on processes that outcome reporting hinges on risk adjustment. And so I can't say that the risk adjustment that we have here in ECMO support really takes away a lot of the reason that your patient is different from my patient as you're looking across centers. But processes measures don't rely on that. Outcome reporting also is subject to bias in terms of surveillance. So if you don't notice a stroke, it didn't happen. Obviously, that's not true. But also, I mean, even more, I think, if we think about mortality and patients leaving our institution, because most ECMO centers are referral centers, you may be missing patients who are dying beyond that. And I think the biggest thing, the most obvious reason for me to look at process measures, if you believe they're right, as they signal how to respond. So if I look and I see that I believe that peak inspiratory pressure is what's driving differences in mortality, and I see that we're different from our peers, I know how to fix that. And so why did we choose that process measure? It's based on those randomized clinical trials that we talked about in that first study. And each of those, they used this. They weren't testing whether this strategy of ventilation was better or worse. And so that's the acknowledgement that this isn't high grade evidence to this, but it's a reasonable anchor point to think about. And so as I transition to talking about improving care by enhancing teamwork, I do just want to acknowledge, right, that I'm not saying that we found the best way, but what I am trying to advocate for is in the absence of a clear best way, that we're still doing something. And I think that's going to be a theme through most of this talk. Improving care by enhancing teamwork. And this is really about reliance on communication, or as Dr. Custer said, communicating the daily plan. And so this was a collaboration between ELSO and the Society of Critical Medicine, which is really about just multidisciplinary team. And I just want to emphasize 3 points. One is just a recommendation from those who authored this work for the decision to initiate ECMO to be a multidisciplinary team. I think most of us don't make this decision in isolation, but it's not easy actually because of when ECMO happens to implement, to actualize this recommendation. And also, and I think probably more importantly, that the decision to withhold ECMO support is also a multidisciplinary approach. And then additionally, that daily care, the establishment of a multidisciplinary care team that is responsible for daily rounds to provide continuity of care, surveillance of quality metrics, and mechanisms to perform case reviews is essential. And so I guess what I would take from that is we also have come to learn that a team helps us to deliver better care. And so we launched a process where we have a regular organized meeting that kind of aims to serve 3 strategies. One is to teach, another is to develop a multidisciplinary plan, and the third is to kind of cultivate consistency. I'm not sure if this has ever happened at your institution. I think probably just mine, where different people decide to approach a similar problem that is uncommon in different ways. And so strategies for alignment and communication, we created an idea of core intensivists in ECMO. And those were folks who were just going to intentionally concentrate experience in, not to the diminishment of what anybody else did, but as an opportunity to make sure that we at least had institutional memory for successful and unsuccessful care. We did that with our surgeons as well. There's, of course, a technical expertise there that might be benefited as well in terms of some of our more technical cannulas that are emerging. We brought in our ECMO specialist leadership, nursing leadership, and then the healthcare team. However that was defined as the patient being cared for. Obviously the intensivist and the fellow, but also potentially, a consultant who may be primarily taking care of the patient on the floor. We felt that it was important to have kind of a scripted presentation to this. There was two ideas there. One is it kind of drove home what the points of significance were to the person presenting the data, helped them not feel uncomfortable talking to a group of folks that they may have been unfamiliar with, but also drove efficiency because we didn't need to meander. It was a 30-minute meeting. We wanted it to be quick and to the point, which also that emphasis on efficiency helped to make sure that we were conveying the plan, because I think a lot of times, at least for myself, I do the least communication when I do the most speaking, because they're like, well, what was the thing you wanted me to do? It helped us focus on the major points, because if you're not talking about all of the stuff that doesn't really matter as much, or you're forced to prioritize because of time, you could do that. And that helped draw in the team. We weren't micromanaging care. We were thinking together about landmarks in care. And then we also facilitated consistency in plan communication by having those key stakeholders in leadership from nursing and ECMO, as well as that bedside team there. And I think this came to fruition shortly after we instituted that. We put a patient on who had actually came 3 weeks into his course to be recognized to have a severe immunodeficiency and was going to require a bone marrow transplant. And that's the kind of thing that had certainly shaken our team before and instituted lots of questions about why or how, and those questions were answered in real time, so they didn't come up at the bedside. Obviously, this isn't a panacea, but it has certainly created some functional benefits at our team. And so, again, I just want to pause here and just hear if there are any questions from folks.
Did you have a hard time getting buy-in for this type of model? And then how did you navigate that?
Yeah, good question. Yes. So it was, I think backing up a step further, we had tried a consulting-based model, which felt much more heavy-handed to folks. But we were leveraged to do this because we had identified kind of two cases back-to-back that were similar to that bone marrow transplant patient, that we weren't doing what we were trying to do. We weren't conveying the plan to the team through difficult cases. I think we were also potentially missing some opportunities as a team. With Gail Onick, one of the folks that I mentioned as a mentor, had recently left our institution. We're looking back a lot. We were saying, hey, we're a great institution. Why can't we just keep doing things the way we were doing it? And it's like, well, ECMO is continuing to progress. So if we want to maintain being a great institution, we need to look forward. And I think that made enough base validity to everybody that people bought in. And then for our team, it wasn't one person saying this is what we were going to do. It was inviting them into a conversation that was informed by intentional expertise.
Do you use the scripted presentation and team discussion prior to initiation as well as daily, or just?
No, this was really built out of like, hey, these are the things we want to focus on, because this was a new idea. Like, we hadn't done this before, and I don't need to know everything that's going on about that patient. We want to understand these elements. Why were they intubated? How long were they on mechanical ventilation? What day of ECMO is it? Where are you at in terms of thinking about coming off of ECMO support and those kinds of things? And so it was really just to concentrate that fellow's initial description of the work in a way that wasn't intimidating as you're coming into a multidisciplinary team, maybe for the first time. It had other unintended benefits as well. And it's a model actually that's worked well enough that our ECMO specialist team is trying to convince our adult team to do the same thing, and that we've layered onto our transplant work as well. This one's a little bit of a stretch, but I really appreciated the comment, which is, you will make mistakes. You will be outmatched by disease both simple and complex, and you will never, ever master this profession. You will learn from your elders, your students, your patients, and your colleagues. You will doubt yourself, but in the end, you will trust your training and effort and experience. And I just feel like this encapsulates what it means, at least to me, to be an intensivist, which is that we are imperfect. We are well-trained and surrounded by an enormous team, and together, despite the unknown, we're able to kind of move forward in a really positive way. But speaking of unanticipated circumstances, this was my first ECMO transport. We blew a tire on the highway, stopped the highway, and transferred the patient. Actually required very minimal input from me, but I was there. Okay. But it is, what to do in the face of the unknown. And I think that there's opportunities to talk about how ECMO and COVID is presenting some of that. And so when I think about all of us have a COVID story at this point, right? Both personal and professional. And as COVID was coming here to the United States in March, two of the places that were hit hardest were New York and Detroit. And Detroit was overwhelmed quickly. And to their credit, the University of Michigan stood up and said, how can we help? They offered a bigger hand than all of the resources that we had. And so we had to think about how we were going to fill in those resources. And so we were fortunate enough to be in our children's hospital, in a place where they had actually built 10 years earlier, certainly by serendipity, not all anticipation, a respiratory containment unit, which is an entirely negative pressurized floor. And so that allowed us to do some things in an efficient manner in terms of taking those 35 beds that were there and the other 35 beds on the other side and making them all double rooms and giving us an opportunity to care for 140 patients on that floor. And that was staffed one side by adults and one side by pediatrics. Before we figured out how we were going to do that in this organized fashion, I just happened to be there when we started bringing in our first patients. And during that week of time, when we started bringing in our first week of patients, we had our first ECMO cannulation. And it was a patient who had been getting worse through the night. The team was a little uncertain about whether he was an ECMO candidate, because again, this was at the very beginning of all of this. In the morning, as the kind of troops aligned, we said, yes, he is an ECMO candidate. Let's mobilize the team. He ended up going into a cardiac arrest. It was an ECPR situation. It was a bit drawn out for a number of reasons. We still hadn't figured out all of the things that we should have figured out, but we didn't know to figure out just yet. The patient ultimately died. And so why walk you through that story? Personally, I mean, this was really hard. We were caring for patients. I just that same night had a conversation with a self-extubated adult about how we weren't going to reintubate the patient if he should die, because we weren't certain how we could protect the team in going forward. The unknown was really strong, and I didn't know if this was the right allocation of resources. But rather than retreating in fear, Matt told me to put together an addenda, and we did. I did that literally in that same unit with our team. Some of the work had been done, but we built that while we were working there. And that helped us to get to some of this evidence. And so I am proud of this work, not because of the academic knowledge necessarily displayed, but because of the way it was done. And so we didn't do the perfect. There's certainly 100 ways to do this, but better. But we actioned something in real time. We leveraged through Matt and the team at ELSO Central an opportunity to ask our centers, our 500 plus centers who are actively entering data, to help us in this moment of crisis and enter data. And I don't know why, but they did. And I do know why, because it's a part of that community that we've been a part of. We got that data, and somehow, as we were all busy, found the time to write this up and get it published within months of it actually happening. And I think informed the field, at least in the best way we felt we could, despite all the limitations of the data. What we knew and what we saw was that from a relatively narrow period of January to May 2020, in patients that had laboratory confirmed SARS-CoV-2, 1,000 patients had already been cared for across 200 hospitals plus in more than 30 countries, and showed a mortality rate, surprisingly, at least to me, at least from where I was starting from, that was very similar to what had been recently reported in Eolia in terms of ARDS. It showed things that we would have expected to find in terms of mortality being associated with increasing age and circulatory support. But that wasn't the end, right? Like this was an active and dynamic process, as we've all learned. So even as we were publishing this data in October, we recognized that, the mortality rate seems to be coming up because we were displaying this data in real time to our community. And so we decided to look yet again. And without kind of parsing out the differences between A2 and B, we noticed that the mortality had increased regardless of kind of how you split the data. Not only had the mortality increased, the days on ECMO support had increased from 14 days to 20 days of ECMO support. And so this was meaningful because this was at the same time. So this got published once again around that October timeframe. But this was just coming off of the Delta variant that you and many others experienced, where we were being inundated. There was a recognition that resources were scarce and that we were allocating them sometimes really thoughtfully and sometimes less thoughtfully. And so just reviewing the findings of the study, we use that timeframe of May 1, not because it's a clearly demarcation in what was going on in COVID, but it was when we had looked before. So our question was, had things changed? And we saw that when we looked at people who went on before May 1 and after May 1, that outcomes worsened over time by 15% in terms of mortality and requiring at least 6 days more of support on average. And so I think this drove home two things for me personally. It was just we needed to have continued surveillance in this disease process, but also that could certainly be expanded beyond that, that the recognition of how something was isn't the way something's going to be. And that as this came out during that Delta variant surge, that we needed to have allocation policies, and that those allocation policies needed to think carefully about the fact that there was an increased mortality in this group and that there was a prolonged duration. And so I'll use this to just reflect generally on how I thought we dealt with COVID in terms of the unknown. And so I think that we relied on established principles in terms of intensive care, what we had learned from ARDS. And it feels weird to say, but you'll remember people wrote like, is this really ARDS? Like we talked about that. That was like, we had to make an active decision to rely on those things. We allocated resources to the credit of the institution there, using a scarce resource committee from the very beginning. We rarely tested our limits, but that was because they had made intentional decisions that aren't necessarily repeatable to shut down the hospital at that time. And I know many other hospital systems shut down without that flux, and that created a lot of angst about thinking about how to deal with other patients. We anticipated resource consumption. And what I mean by that is we thought we had really brilliant folks building models that predicted where we would be. And we made that resource allocation, not thinking about where we were then, but where we would be across time. And that it became really relevant as these length of time moved on. And then we observed the care that we were providing and shared and borrowed from others' experience. This is just that ELSO building platform, but it was much more than that. It was writ large, the community of physicians who were taking care of these patients through a variety of circumstances thought to share experiences and hopefully learn from those. And I think that's the other thing, is that we were learning as we delivered care. And so what about COVID-19 in kids, which is a space where there's even more opportunity to learn? And so this is all borrowed from that kind of real-time reporting platform on the ELSO registry that this was from February 22nd, despite my not having changed the date there. But the ELSO COVID-19 dashboard does give you all of this information. I've just layered it into some tables. So the age obviously is different. The BMI is pretty similar. I find this to be resonate clinically, but also be surprising to me, which is that gender difference that we see between a male predominance in adults isn't there. And then maybe a little bit more use of renal replacement therapy in of acute recognition of acute kidney injury in our adult patients. And then when we look at that, and sorry, I'm focusing here just on that ARDS and pediatric ARDS cohorts. And this, apologies as well, I should say 146. But there were roughly 80% of patients in both groups that were receiving non-invasive ventilation. It looked like the pediatric group was transitioning to ECMO support a little bit faster than the adults on average. And the peak inspiratory pressures, PF ratios were relatively similar, as was the utilization of supports like neuromuscular blockade and vasoactive support. Notably, the prone positioning was quite different. I think this resonates with what our clinical practice is. And then, the use of those augments in terms of glucocorticoids and remdesivir were quite similar. Outcomes, obviously, as it should be obvious, was different. And so there was a 44% discharge to home compared to 24%. And the tracheostomy rates were quite different in terms of 27 and 49% with a days on ECMO of 25 versus 21. And so I'll just wrap up by saying, I think what I hope to talk about here is have conversations around where I feel like there's still unknown. And unknown, I think, can feel daunting because it's not prescriptive in where to go, but I think it's also opportunity. And so I think it allows us to think about how we design systems that enhance learning as we're delivering care. I've given 3, I think, examples of that through the talk. I think that it helps us to think about designing clinical care that enhances teamwork and collaboration, being intentional about that. So that was, Jocelyn, you'd asked the question about like how we got to that. I mean, it was through a failed experience, but then it was with a deliberate attempt to bring together that. We wanted to facilitate recognize that you can't do this research in your center. This is not single center research. That's daunting, but also fun. Like I've told Matt, one of the things I love most about Ascend is the fact that I get to talk to folks from a lot of different sites and hear how folks are doing things differently across the country. I think finally, in ECMO in particular, there is so much opportunity to improve the care through even small advances in the research, and that because of the significant mortality and complications that are accompanying with that those research changes may actually save lives, and that even just the hope of that is really exciting to me. Of course, this work is much of it and not my own, both because it came from the published studies I referenced, but also because it relies on the backbone of our team. I come from a phenomenal team, just like you guys have here, of ECMO specialists, a phenomenal team in terms of Ascend, of a research team with a project manager, Kelly. We've done a phenomenal team in terms of my mentors, many of which I have already named, but I just, it's an amazing team to be part of, and it's an exciting journey to travel. So that is all I have for.
That was fabulous. I'm going to start off with our virtual audience here. This important Barry has asked, do we have any sense of severity of illness going on in later phase? That is to say, more willing to put worse patients on ECMO with more comfort putting them on ECMO?
I don't have any research evidence to kind of point me one way or another. My sense is that this ebbs and flows a bit across teams, but on average, when we have looked, there hasn't been in the measured indices evidence that patients are sicker going on across time. That was one of the things that we hypothesized in that kind of comparing that earlier data to the later data, that there'd be kind of clear indications that people were sicker, and we hadn't seen that. I think probably it's an averaging out. I think that centers certainly maybe as they've had some successes and hit some lulls, feel a little bit more comfortable extending that. And then I think centers, as they kind of hit ramp ups in cases or have some tougher circumstances, titrate that back. And I think that overall it averages out to the same, but I think there are probably microcosms of change going on across centers and across time. Yeah.
Right. You talked about the increase in mortality and length of time that may split. Have you got any Omicron data yet that you've been able to see anything?
Yeah. So there are certainly, we have made an intentional decision not to really talk about the strains, because I don't think I can do it in a way that I have any confidence that I'm talking about the strain. It may be possible in Omicron, if you focus like at a country level, the United States, because we kind of know when that happened. But for the rest of them, we don't have enough good data about, hey, this patient had this strain. And it's because we're not collecting that in the registry directly. It's hard to have a sense of when those strains were predominant. So the short answer to your question is no, but I think there's an opportunity there with Omicron if you take a more focused region because of the kind of hit that you could look into that. I will say that, things have stabilized out. There's not a continued trend of increase, and our own personal feeling about why those changes happened was much in the kind of analogy of the CDH population, I think, or sorry, the neonatal population, that in the beginning, before we had kind of general use of inhaled nitric oxide and general use of surfactant and general use of high frequency oscillatory ventilation, that we saw with that inhaled nitric oxide in randomized clinical trials, that the reduction in that meconium aspiration population relatively increased our CDH population, and we saw a worsening to stabilization of outcomes. And I think the same thing was happening here, which is in the beginning, we were providing but not as good treatment. In fact, a lot of patients actually were receiving anti-malarial drugs. And so I think that ECMO provided an opportunity to just allow the patient to recover through the illness that they might not have had without that support. Whereas when you had the steroids and all of the other appropriate therapies, the recognition of general ARDS management, that we started to see patients that were more recalcitrant to basic therapies. Another thing that others have posited is that also because of the almost universal use of non-invasive ventilation, there was yet another rung that you needed to move for, that you needed to actually have failed non-invasive to get to invasive. And some have also hypothesized that maybe there was patient or in self-induced lung injury as well on the non-invasive support. Yeah, Justin.
What were some of the things that made your center able to be, you think, so nimble and ready to respond? I mean, there's other healthcare systems that move at a much more glacial.
Because I'm consolidating months of work into a slide.
But even like the registry, for example, I mean, there's places that still can't track their data, right? So like what was there at your place or wherever that enabled you to do that? Because I think that's important information, right?
For sure. So I think we, and I shouldn't say we, I should just say Matt and others at ELSO, made an intentional decision to leverage the political clout that ELSO had because of that sense of community to ask, hey, look, I know you're busy. I know you don't have time, but for these patients, can you please enter the data? And they did. And I think, that comes back to that sense of community around ECMO. I think that's probably in most places. It is where I've experienced it. It is what drew me in. And it is certainly a fabric of that community. And so I think, Matt could probably echo some of these, but there were real comments about people saying you absolutely shouldn't do this and people feeling you absolutely should. And I think that we recognize that we had a duty to try and answer this question. I think people rose to that duty. A lot of people did a lot of things
So if you give me a second to just put this in context of when we were deciding to do this, and it's why what Ryan has done is so important. At the time we did this, literally all of us had just gotten off of a plane from South Africa from an ECMO meeting. And it was all through the roof in China at this point. And a week after we got off that plane is when America shut down. And so it's right at the beginning. At the time when we're talking about doing this, the only reports out on ECMO use in COVID are 90% mortality rates in China. And that's it. And so the papers that are coming out very rapidly and the news stories are, you shouldn't do this. Because we've got a population of centers and investigators who are willing to be aggressive and who, quite frankly, have been through something similar to this before during H1N1, we used that as our past experience to leverage and say, guys, we want to do something similar to what we did during H1N1, which was something that I did when I was in Ryan's position at that point, and said, we're going to have you guys fax just the bare minimum of information to us so that we can start to get some information on this. Ryan and his team were able to put together an amazing, online version where people could do this quickly, where we could share the results live. You know, you go on the website right now and can see what the up-to-date numbers are. And as we start getting centers who are used to doing ECMO and everything, you see that mortality that started at 90 creep down to what we would expect in this situation. Brian's first publication, you know, basically showed for the world, not just here in the US, so worldwide centers, what we could do. The second point that I would make, though, is that he had the academic courage and academic bravery to then, when we saw those numbers were getting worse, to go back to the worldwide population and go, hold on a minute, guys, something here has changed. With our data, we don't necessarily know what that is. We don't know, is it a different variant? Is it the care we're providing or what? But again, that kind of academic courage to say, let's continue to look at this and see how things are going, whether we're getting better or getting worse, again, is a big part of this. So the last point I just would end with this is, again, we started this with 90% mortality rates and nobody willing to do it. We're now at a point where worldwide we've got over 40,000 patients that have been supported with ECMO through COVID-19, with roughly 50% survival of somewhere around there. Roughly 20,000 people around the world who are alive now because of this technology and because of the work that Brian and his team did.
Justin, I think it was just also like, I think people just, thank you, Matt. But I think like people just saw the data and I think they needed it, as Matt has articulated. I think that fact that it was coming in live was really, really helpful.
Yeah, and I mean, it's nice in ECMO, but we take care of a lot more patients besides ECMO patients.
Yeah.
And so the idea is to take the lesson and replicate it. And
So
how do you make it to a bigger scale? Because we need to get better.
Small. I think you take it to a bigger scale by being pragmatic and small. I think so many times in so many police calls, we talk about, well, if you're getting this, can you get this? And because you're getting this, can you get this?
It's too much.
And then what was 5 minutes is now 4 hours. And where a center has resource for 5 minutes and can prioritize 5 minutes, they don't have resource for 4 hours. Sorry. Yes. Apologies.
Okay, well, I think we're gonna have to end there as we're coming to the end of the hour, but I'm gonna just summarize what Jim Fortenberry just sent. It is congratulations again to the work that you've done that's enhanced the ELSO registry as a quality benchmark tool for centers. And I think the work that you've been doing is amazing and how it's impacted the COVID pandemic. So congratulations.